Good morning, everyone. Good morning. So I'm Tilly Ryan. I'm the Chief Executive Officer of Melanoma Patients Australia, and I am given the wonderful opportunity of being your MC for today to welcome you all and just keep an eye on proceedings. I really appreciate you giving us your Saturday morning to come and hear from some really great speakers about melanoma. Melanoma in the Toowoomba community is an issue, and in this region there are many people affected every year. Nationally, we have a melanoma issue because Australia has the highest incidence of melanoma in the world. Over 12,500 people are affected by melanoma each year, and 1,500 people pass away from melanoma. That's a staggering statistic. What's even scarier is that as a nation we have the dubious honour of being the melanoma capital of the world, and more specifically Queensland has the highest incidence of anywhere. So here in Queensland we unfortunately deal with melanoma at the coal front, and Melanoma Patients Australia, along with Cancer Council Queensland, try to work hard to assist patients dealing with melanoma, to assist people who are caring for someone who is on the journey of melanoma, and also people who may have had past sun exposure or who have a family history of melanoma and skin cancer, who may have some concerns about how to prevent their risk of getting melanoma and actually then being diagnosed. So today we're fortunate to be joined by some wonderful speakers, including Dr. Eddie Roos from Cosmetic Elegance, and also Bronwyn Smith, who's come up today from the Gallipoli Medical Research Foundation based at the Green Slopes Hospital, and each of those will be giving different perspectives on melanoma. Firstly, looking at it from what melanoma is and how it is treated and diagnosed, and also then melanoma and clinical trials. So the treatment for melanoma over the past 20 years has been rather standardised, and in the recent few years we've seen major advances. Just this week we're hearing more news of clinical trials gaining access for patients to try new treatments, and these are having astounding results in patients' outcomes, and hopefully we will see a change in the way we have melanoma in our community. However, there's a long way to go. We're not looking at a cure necessarily for every patient, so it's really important, days like today, that we get access to up-to-date information. So before we commence hearing from the speakers, we're fortunate to have Councillor Sue Englert join us from the Toowoomba City Council, who will formally welcome you today, and I ask her to come forward now. Thank you.
I had to lower it down just a wee bit. Thank you very much, Tilly. As we begin today, I would like to acknowledge the Gibel and the Jarawar peoples as the traditional owners of the land on which we are today. For tens of thousands of years, their footprints have covered this country. They have continued their connection with the land and sustained generations of nurture, healing and spirituality. I acknowledge the pain of our shared history and commit to righting the wrongs of the past. I do this as part of a commitment to walking together in reconciliation. Good morning, everyone. I'm very honoured to be here this morning, and I, in a way, don't really know why I was chosen, but I just am here to welcome you, and I thank Amber for offering me the invitation to welcome you all this morning. But I do have to say that I too have shared the path of having a melanoma, and my middle girl, who will turn 41 this year, was just starting year one, and we had her uniforms and everything ready, and my husband at the time brought a friend home who happened to be a doctor, and I was making them some sandwiches, and he pulled my arm across and he said, if I were you, I would get that little mark on your arm checked. So, you know, as you do, you put it off and you don't do too much about it. We're all guilty of that. But I did go then and get it checked, and imagine my surprise when it actually came back that it was a melanoma. But I guess the good news about that is 36 years ago now. So I can say, well, you know, I have survived. But at the time, I'll never forget the feeling how I felt when I was told, because that long ago too, there wasn't much information that we had, and it was rather scary because I didn't know whether I'd come out with my arm chopped off, my head chopped off, or what chopped off. I can remember being in St Vincent's Hospital and the fires were burning. I don't know whether anyone else here remembers the fires that were burning in the middle to late 1970s all across the range. And St Vincent's Hospital, yes, it was a traumatic journey. But I guess all of you here too have had those same journeys. And if it's not you, it's someone that you love very dearly. And as I say, it can be very daunting. And these sort of get-togethers are very good, not only for information sharing, but in my view, they are most important as a support to know and to see that other people have done so well and to get advice about how you're feeling. And, you know, if you feel alone, it's good to have other people to be with. I would like to ask, how many of you are not from Toowoomba? Are you all from the city? You are. So for those people who are visitors, I would just like to say a very, very big warm welcome to what I think is the most beautiful place in the whole world. Welcome to the top of the mountain. And for those of us that do live here, today let us look around and enjoy and not be blinkered to the beauty of where we live. Toowoomba is around about 800 metres above sea level. So we're fairly high up here and the weather has been pleasant over the last few days. Look, I can't talk about anything medical, but I can only talk about my life, and I am very, very happy to be here this morning. And I hope that you all get something out of today. And I thank in particular the organisers, because looking back on my life, it would have been wonderful to have had somewhere to go, someone to talk to, because even your own family didn't really know what you're in for. And to be quite honest, I don't think the doctor did either. I don't think they knew, they knew a bit, but they certainly don't know as much as they do today. And as Tilly mentioned before, every week there are new steps forward. Every week there are better ways, less invasive ways for patients to be treated. So I'd like to welcome you all on behalf of the organising committee, and I hope that you all have a most fulfilling day and that you go away from here renewed in strength, both in mind and soul. Thank you very much.
Thank you, Councillor. Sorry, I have to lift it up again. So, look, firstly, I should just point out a few things before we get underway into the speakers. And I should definitely point out that we are recording today's presentations. We had a number of interested people who wanted to attend who are unwell, and we also have people who wanted to attend from around Australia who are part of our network, and so we upload these recordings onto our website, and it means then that you can then access it after today. So the important thing about today is that you can listen, hear it, but then go back and listen to the recordings if you so choose. It will be available through the Cancer Council and also MPA, as well as through the speakers themselves. So if you have any objections to being recorded, please let me know, but they're just focusing on this area here. So we are very fortunate indeed to have the founder of Cosmetic Elegance Clinic join us. Dr. Eddie Roos is a long-term citizen from up here. He did have a rather colourful journey to get here. So he graduated from medicine in 1988 and worked in South Africa for 10 years before coming to Australia in 1998. Dr. Roos is the founder of the Cosmetic Elegance Clinic in Toowoomba and has been doing this work since 2001. In both Toowoomba and Brisbane. He has got a keen interest in laser work and light-based therapies, and quality of service is very important to him, along with keeping up to date with cosmetic medicine. I think it's important to note that he has developed a real interest in skin cancer working in rural Queensland, because this has shown him and exposed him to the effects of long-term sun exposure. He's got a very keen interest in this area of skin cancer surgery and is doing his best to assist in preserving his patients' cosmetic appearance when they're receiving treatment. From a patient perspective, that's a really important aspect of the treatment journey. It's important to also note that Dr. Roos is a member of the Australian Skin Cancer College of Australasia, along with a number of other organisations, which are too many to list. But I will say that Toowoomba is really lucky to have a man of his calibre in your midst, and we are very grateful today to indeed welcome Dr. Roos. So thank you.
Thank you for that introduction, Tilly. I think it's... I'm not as wonderful as you make out that I am. I mean, I'm just, as Sue said, you know, I'm just a dumb doctor and I'm still learning. So, no, I think, you know, doctors are human. And working in the field of skin cancer, it's an emotional field that we work in. And I think for us, it's just, you know, we always try to do our best. That's just my philosophy. Every day I go to work, I do my best. I want to do the best for each patient that I see, with the limitations that we sometimes have. So that's just my disclosure. I mean, I do work at Cosmetic Elegance Clinic. I do have specialist registration in general practice. I've got a special interest in skin cancer medicine. Also interested in laser work as well. We have about 12 lasers in our clinic, which we use for many different applications, from tattoo removal, but also for treating solar keratosis and sun-damaged skin. So, and for acne scarring. So there's a lot of things that we do over there. So skin work is what I do, and even treating people who's had skin cancers excised, treating their scars to actually give them better looking scars after they've had the surgery. And I've been working in Toowoomba for about 8 years. So what is skin cancer? Skin cancer is just an uncontrolled proliferation of cells in the skin that's been damaged by ultraviolet radiation. Now, in the skin, there's different types of cells. That's why we have different types of skin cancers. So we have the basal layer where the basal cells are. We have the squamous cells, which is above that. And we have Merkel cells, which is like a nerve type cell. And we have melanocytes. And that's where melanoma comes from. So we talk about non-melanoma skin cancers, which is BCCs, SCCs, and the Merkel cell tumors, and then melanoma, which is deriving from melanocytes that actually are damaged, and then they just start to proliferate, and they act abnormal and cause the cancer. Yeah. The question always is, what causes skin cancer? And I always say to my patients, you need to have the correct genetic makeup and the environmental exposure to cause those cells to change, and that will make them become cancerous cells. I have patients who are roofing contractors who work with a pair of boots on and still today work just with a pair of rugby shorts on, and they spend all day in the sun. They're as brown as they can be, and they don't have any skin cancers on them. Why? I think it's their genetic makeup. They are most probably just one of those lucky people that will never get a skin cancer. Then we see other people who actually have very little sun exposure and develop many skin cancers. Why? Because they only need a little bit of sun exposure to cause them to have the trouble with that. So 90% of melanomas are caused by the sun. 14% of adults, 24% of teenagers, and 8% of children will be burned by the sun every year. Now, we go to the beach and we still see people laying in the sun, tanning in the sun. I get burned because I will walk to my car, see some weeds in the garden, and I'll just stop and I will just start pulling them out, and then a half an hour later, you know, I go in and I'll have an area where there's a little bit of more sun exposure on my skin. It's not intentional. We just get that. We think we're just going to walk somewhere and then we have to wait and stand outside. So a good idea for us is to actually make sure we always put sunscreen on. And, you know, we don't always wear a hat. So tanning, you know, when I was young, my grandmother always said to me, you look pale, get outside and get some sun because you look like you're sick. And it's still a thing like that. I mean, we do still think that people that are tanned is, you know, It's a sign of well-being that we are actually healthy. And when we're pale, it's not. But I always say to the patients, I'm going to develop the sticker that we put on our bumpers, and it says it's cool to be pale, because we all want to have the tanned look, but for what? I don't think it makes much of a difference. So UV radiation causes the aging of the skin. And today in the Chronicle, there was the thing about smoking causing, aging, and I think it was on the news this morning as well. But we see with the cosmetic work that we do that ultraviolet or sun exposure does cause premature aging of the skin. So why do we actually want to go into the sun? You get these people who lay on the beach and then they come in and they want their Botox and fillers in the week, and you say, it doesn't make sense. So we just really have to be careful about sun exposure. What the UV rays will actually alter the DNA in the cells, and that's when the cells become abnormal and they act in an abnormal way and become cancerous. Solariums, well, thankfully I think they are now banned in Queensland, but when they got banned, the places sold them. So there are still people who actually have solariums at home, and they're getting their friends to use them. I do not know why, but we will still see the problem. And we know that the solariums has 5 times the midday radiation of midday sun. So solariums are just really not a good thing to have. We, about 10 or 11 years ago, bought a beauty salon in Toowoomba. It had a solarium. First thing I introduced is we need a consent form that people do this on their own risk and that they know that they're going to have a higher risk for skin cancer. And 4 months after we bought the place, we sold the sunbed because I could not justify being a doctor doing what I do and then having a solarium in one of the associated businesses. Okay, then babies in the sun. When we go to the beach, we always see these babies and they've got nothing on and they're sitting on the beach and running around, and not many of them actually have sunscreen on. And it's been proven that that early childhood sun exposure will affect our risk for having skin cancers when we're older. So, the big thing for us is if we have family with young children is to say to them, please make sure that your babies are protected. Thankfully now we have the rashy shirts and things like that the babies wear. That's good that we see that. So, and sunscreen is safe for use in children. So I do think that the Slip Slop Slap campaign has actually done a lot, and we should be doing that sort of like every day. So, slap on a shirt, slap on some sunscreen, slap on a hat, and then try and be in the shade. We don't have to be outside in the sun. And then sunglasses, because you can actually get skin cancers on the retina as well. So having a good pair of sunglasses when we spend a lot of time outside, that's important. And then also to remember when you wear sunglasses that you get reflection of them, and then we'll see a lot of skin cancers just on the upper cheek area. Now, this may be old news for you, but 2 out of 3 Australians will be diagnosed with skin cancer by the age of 70. The incidence has risen over the past few years, and melanoma incidence has risen by 60% from 82 to 2010. I think that's partly due to us looking for it. I don't think there's more melanoma. There may be more, but I personally feel that melanoma and skin cancers will decline as we're doing the preventative measures, but we're actually looking for it now. We haven't been looking for it before. Before, we waited until somebody came and said, oh, I don't like this thing on my face. It's gone darker. And then we've done something. Now we have people coming for preventative checks. So even non-melanoma skin cancers has increased as well. It's non-melanoma skin cancers, that's the BCCs and SCCs. They are twice as common in men, most probably because men work more outside. We do see a lot of them as well. So melanoma, it's the third most common cancer, and it's most common in the age group of 15 to 45. And if I look at our audience here today, how many people over here are, who's under 35? Okay, good. So 4 of us are under 35. Who's under 45? Well, there's a few more hands go up, but the majority of us that are over here are actually over 45. And we all think that, skin cancer is something that happens to old people. No, it doesn't. It happens to young people as well. And melanoma, there's more of a emotional thing to melanoma because people die from melanoma. I have patients who say my cousin died when she was 27 from a melanoma on her back. Why? Because she didn't see it. She didn't think that it was going to happen to her. When we're under 40, we're bulletproof and nothing can happen to us. But the worrying thing is that melanoma is a young person's disease. It affects more young people than old people. And because young people don't think that it's going to affect them and it's going to be bad, they often have a bad outcome because by the time it's being diagnosed, it has metastasized. So I do think that we need to go to the schools, to the high schools, and actually say that to them. And that's maybe where MPA can go to and say, target the high schools and work with them because teenagers want to have the tan, they want to be cool, but they are also at high risk. In our clinic, we see the majority of people with melanoma in our clinic that we see are below 30 years of age, or 35. We see a lot of people in their 20s. About 4 weeks ago, I had 3 girls come in. So one girl had an excision of 2 lesions, and the other 2 girls just came in as their friends. They're all in their 20s. And one of the lesions that we removed on the girl's leg was a melanoma. So she came back for us to remove the sutures and give her the results. And while we were doing this, the 2 girls were over there, and one said, I've got this thing over here, but maybe I'll have it looked at. And the other one says, no, I've never had it looked at. I'm too young. And when she came back, I said to her, now, what are you going to tell your friends? And she said, I'll tell them to come and be checked. So we often find that many of the melanomas that we pick up, or most of the melanomas that we pick up in our clinic, is because of people coming in for their regular screens. And I must say, young people do come for their checks, which is really good. I think the message is getting out there. The worrying thing is there are still some guidelines saying that having regular skin checks doesn't make doesn't change the outcome of what we see with melanoma. I tend to disagree with that because the majority of melanomas that we pick up are picked up as Clark level 1s or Clark level 2 melanomas on people who come for regular checks. So that would have been picked up later on as a Clark level 3 or 5. That would have given them a worse prognosis. So in 2010, there was 11,405. Tilly said it's 15,000, I think is what she said now. So a lot of people die from skin cancer, So what's the symptoms and, how do we diagnose it? The key with diagnosing skin cancer and the outcome of skin cancer is early detection. The sooner we diagnose it, the better the outcome. Because melanomas they'll start spreading in the skin on the surface, but they also start to dig in deep. And with the outcome with melanomas is how deep it digs into the skin. Even for us to remove it, to remove a small 0.5 millimeter, 5 millimeter lesion on a face is much easier than removing a 1 centimeter lesion on the face. People should know their risks as well. So if you have a family member that's had a melanoma, you are at higher risk of having a melanoma. So for all of us over here that actually had melanomas, it's important that we tell our family. We have to tell, I always say to patients, tell your parents, tell your siblings, and even tell your grandparents as well, because we actually have diagnosed melanoma on grandparents from children, or from their grandchildren who had melanoma. So know your skin. You cannot know every little spot that's on your skin, but when you get out of the shower, dry yourself, have a look in the mirror, because we often have people who say, you come into this, I've got a patient who'll come in and say, I don't like this mole on my leg because I haven't seen it before. Now, it didn't pop up overnight. It just gradually got darker and darker, and one day when they look down, they see it's over there. So know your body. If you are concerned, go and get some advice. What to look for? It's crusty, non-healing lesions, small lumps that has different colors, red or pearly colors. Now that's for all type of skin cancers. New spots of freckles, or a freckle that just gets darker. If it changes size, shape, color, or texture, a sore that doesn't heal in 8 months' time, Go and get somebody to have a look at that. Because all melanomas are not black or brown. When I worked in Gundawindi, there were two ladies that I saw in the general practice over there, and they both were married to bank managers. And one had a sore on her arm that just wouldn't heal, and she said, it's nothing because it's been there for some time. And I said, no, let's just take that off. It had some blood vessel changes in it. It came back as a amelanotic melanoma. So it's a melanoma that doesn't have melanin or the brown pigment in it. And the other lady had a sore on her leg. Same thing. It was there for about 2 months. That came back as a melanotic melanoma as well. So it's important that we realize that if anything that doesn't heal could be a skin cancer. Commonly, most common in the face, if that's the case, it will be a basal cell carcinoma or on the back or so, but we really have to have a look. And then the other thing is moles that are itchy. If you become aware, or people become aware of a mole, it's important that they, keep track that that mole is itchy or irritated, because when there's changes in the body's immune system will pick it up and you will try and fix the changes. And that can sometimes cause an irritation. So it's a fact and a known fact that if a mole is being irritated for some time, that it is a good chance that that mole could be a melanoma or a severely dysplastic nevus. So treatment. With melanoma, still treatment is the treatment of choice. If we cut the lesion out, it's gone. We need to cut the lesion out with a clear margin, and depending on the stage, the Clark level, how deep it's spread in, and also the type of melanoma that it is, the margins have to, will vary. So anything from a 0.5 millimeter, a 5 millimeter margin to a 2 centimeter margin around some of the melanomas is needed. So the pathology will usually give us an indication of what type of melanoma it is, where it is spread, and it will also give us an indication as to, on secondary excision, how much we have to take out. The other thing that the pathology will show us as well is if this cancer has moved into the neurovascular bundle. So that's in the skin, we have nerves and blood vessels, and they will go up into the more superficial areas of the skin. If the cancer gets into that bundle, it spreads quickly. Now, melanoma is also it's also emotional because of the TV ads that we see, and they are very graphic, and we can all remember the ad that we've seen, the black spot, and then you see the black going in through the body and spreading. It doesn't always happen like that, but that is a graphic way of how it does. If we can catch it before it gets into that that stage, and that's what the neurovascular infiltration is it's gone into that bundle and it will spread like that. We try to catch them before that. Good. So there's also some non-surgical treatment, not for melanoma, but mostly for the non-melanoma skin cancers. For that, we would use a bit of cryotherapy, so we can spray some of the superficial skin cancers. There's also some of the creams like Eldara or Effidix that you can be using for some of the non-melanoma skin cancers, not melanoma. And then you can also burn them with laser. We can curette them and burn the base with an electrical current. And also for some of the non-melanoma skin cancers, radiation treatment is used for that as well, and especially if there's been some neurovascular involvement with that as well. And so if we think about melanoma, so I'll just, melanoma doesn't happen overnight. You don't go to bed and have no melanoma on your body and then tomorrow there's a melanoma. You would have to have a mole that becomes abnormal, gets more abnormal, more abnormal, more abnormal, and then a melanoma. Now, our pathology reports that we get back will often say it's a dysplastic nevus. A nevus is another word for a mole. Dysplastic means there's abnormal cells in it. And some of the pathology companies will say it's mildly dysplastic, moderately dysplastic, severely dysplastic, and then a melanoma. And then some of the reports will come back and says it's a severely dysplastic nevus. Could also be an early melanoma. And it's like the pathologists don't want to say yes or no. But once we have a diagnosis of a severely dysplastic nevus, I treat that as a Clark level 1 melanoma. We want a 5 millimeter margin around that because that is a lesion that's significant, that's got significant abnormalities in the lesion, and that some pathologists might call a melanoma and some not. So it's important. People think, oh, it's just a dysplastic nevus, it's nothing to worry about. We can have a dysplastic nevus that stay dysplastic for the rest of our life, but it actually has taken some steps to change, and the body, our immune system will try and keep that in place, but if your immune system can't do that, it may develop into a skin cancer or into a melanoma. And the same thing with sunspots. The brown, the dry little flaky bits that we get in our face, they are sunspots or solar keratosis, so they're not cancerous, but they're pre-malignant. About 20% of them will actually change into most commonly squamous cell or basal cell carcinomas, and that's why we treat them with the creams or we spray them with the liquid nitrogen. It's news that Australia and New Zealand is the highest, we've got the highest incidence of melanoma in the world. The risk for diagnosis at age, to have had a diagnosis of a melanoma at age 85 is 1 in 14 for men and 1 in 24 for women. So again, it's more common in men, and I do think because men may be more sun exposed than women. It's the 6th most common cause for cancer death in men and the 10th most common cause for cancer death in women. So how do we diagnose it? We use a skin check. There's the ABCDE, and we also use it in the dermatoscope. So we look for asymmetry in the lesion, irregular borders, uneven color. If the diameter is more than 6 millimeters, and you don't have to have all of those features over there, and you can have an uneven color mole that's not a melanoma as well. So we look for some changes in the mole, and then we look for chaos in the lesion, because most of the moles actually has got a nice structure when you look at them. And if there's changes in that, that's what we look for. Then we use a little dermatoscope, which is a little handheld device, which is nothing else than just a light. It's a LED light and a magnifying glass with a polarized lens in it. So we can actually have the light polarized or non-polarized. So with that, we can actually see the structure, we can see the colors, and it's magnified, but we can also see the blood vessels, and it actually takes the reflection of the light on the skin off if we use the polarized section. So there we just look for the eccentric structures in the lesion. We look for the thickness of the lines and whether they branched. We look for grey and blue structures, black dots and clods, peripheral and radial lines and pseudopods, white lines. We also look for blood vessels. There's certain blood vessel changes that we see with different types of skin cancer. And then there's this term which is called chaos. And it just means that that lesion doesn't grow like any other lesion. You can just see there's no structure in the lesion. So there's been in the news something about the terahertz laser. I don't know, you may have heard that. It's a laser that is being developed and tested in Queensland to actually reduce the number of lesions to be removed. Now, it's new, and I think it's still years away. We have a picosecond laser that we use for tattoo removal that we bought last year. It was launched, the first ones that came in. We were one of the first 3 clinics to buy one last year in November. The first picosecond laser was built in 1995. So that's when the technology was developed. It took them until last year before we could get one in Australia. It was available a year before in America. So yes, it's great. Anything that will come will be good to actually help us. I have patients who say to me, don't you have one of those machines that you can go in and scan and check for all your cancers? They have them in Brisbane, they say to me, and I say, oh, really? I said, I don't know about them, but if there's one available, I'll take 5, because that means I don't have to do all the skin checks. There's none of those things available yet. This is promising, but I do think that it will take some time before we get any of these things coming. So just staging of melanomas, there's different ways for staging melanomas. And as you can see over there, at Clark level 1, it's just sort of like in the epidermis. Clark level 2, it's just going through the epidermis. 3, it's going into the papillary dermis. And then 4, when there's little islands of it. And then 5, when it's gone into the fat. And having that as one of the staging things, it also will affect our 10-year survival rate. So Clark level 1 and 2, you can see over there is really good, 99, 96. Clark level 3, it comes down to 90%, which is still fairly good. Level 4, 67, still good. Level 5, 26%. So the deeper the cancer grows in, the worse the prognosis for us. Now, Clark level is one thing that we can do. There's other things that we use as well. It's the Breslow thickness. It just measures how thick the melanoma is. If it's less than 0.75 millimeters, it's always a better prognosis. If there's ulceration in the lesion, it's a worse prognosis. We also look at how many mitosis there are or changes there are in the cells under the microscope. It tells us how aggressive the melanoma is. And then there's some different types. It's, superficial spreading, nodular, lentigo-maligna, acral lentiginous, desmoplastic, neurotropic, and nevoid. So all of those things will determine how aggressive the melanoma is and what our survival rate may be. Surgical margins, it just, depending on how thick the tumour is, what type the tumour is that we have, will determine how much we take around it. Lymph node biopsies, it is not done routinely with the Clark level 1 and 2s and 3s. 4 and 5, yes, and if the Breslow thickness is over 1 millimeter. So what does melanomas look like? This is a lady that I saw, this was removed on Tuesday from a patient of mine. Came in for a routine skin check, and we picked that up on a calf. So just a small little thing, doesn't look like anything. If we then have a look at the dermatoscopic view, and we can then see the little darker pigment that we can see, or a network that's coming out of the lesion. So that is actually Clark level 4 melanoma. So, and then I've just put in some other melanomas for us to say that, they don't all look the same. Those ones look very much the same, and I'll just flow through these ones for you. So they can look just like many things that we have on our body, and these all come from a textbook. There's just a little bit of ulceration. So ulceration is usually one of the worst prognostic features that we would see. You can also get them on the feet and in the nails, or the nail bed. That's a melanoma as well on a face. That's a patient of mine that actually came to me last year, and she was going to get married for a second time. She's in her 40s, and she came and she wanted to look more beautiful for her wedding, and she said she wanted some Botox and some fillers, and I always give them a mirror, and I said, so what's worrying you? And she went like this, and she said, I don't like this over here. And I could see the hollowing in her face, and she needed some filler. And I said, what's that on your finger? And she said, oh, that's nothing. She's from out of town. She said, I went to the doctor, and the doctor took a little scraping of that, and they think it's a fungus. I said, no, it's not a fungus. And I said to her, I think that's a melanoma that you have over there. And she said, no, I don't think so. I said, the scraping's not going to do that. We need to take a biopsy of the nail bed. And that's what we've done in the other photo over here. So you actually have to lift the little cuticle skin over there and then get into the nail bed, take a biopsy from that. That was a melanoma. So she's lost a finger. Nail, or melanomas in a nail is not common, about 1 in 4 million per year. So very lucky. I mean, I think the Chronicle did an article on the lady, and I think is it Take 5, which is the magazine that's got all the puzzles and things in it. She was in that as well. So very lucky. I mean, this lady came just to have some Botox and fillers done, and we picked that up. So the take-home message is that if we don't look for these things, we will not find them. Now, I haven't gone into the research and melanoma trials, and I think that's what you're going to do. That's for the clever people. So, there's a lot of things happening. I do think that melanoma is here. It's still going to be here with us for some time. The big thing for us is the young people, and I would just like to thank the melanoma, MPA Melanoma Patients Australia, for this little booklet, because every patient of mine that actually gets the diagnosis of a melanoma gets one of these little booklets. And it explains a lot of things in there. Sorry, I mean, tell you, I'm just... when we get somebody and you give them the diagnosis and say you've got a melanoma, there's different ways that people react. Some people cry, some people swear, some people punch the table. It's very emotional, because you know what? If you tell me I've got a melanoma, what do I see? I see the TV ad and I'm going to die. It's not true for all of us. We're all going to die one day. And I always say to them, one of us may die on our way home in a car accident. It may not be the melanoma that's going to kill you. So I think, we really have to look for this, and we need the work that you guys do to support those people, because they may come to one meeting, or just to say there's some people you can ring who's had melanoma, who's lived through that. It's great to have that. And then I'll do a little plug for where I work. This is just the information brochure. There's some, we have a 7th birthday coming up on the 12th of June, so we invite this ad in the paper today as well. All our patients and everybody who wants to come can come and spend the evening for a couple of hours with us, have a drink of champagne and have some nibblies and see what we do at our clinic, because the name is maybe a little bit misleading when it says Cosmetic Elegance Clinic. It's not just about that, but every time when we do an excision, we do that with the best cosmetic outcome in mind for our patient. Thank you.
Thank you. So, Amber, I might call you forward to do your magic again. I've been sworn away from computers. Look, I want to reiterate and say thank you to Dr. Roos for a wonderful presentation on particularly melanoma in situ, so melanoma that is able to be excised. And I think that some of those graphic images definitely highlight for us the magnitude of melanoma. We in the room may have some understanding of that through our own experience, but to have someone who is thinking holistically about the care of the patient, not just making sure that the whole melanoma is removed, but also then the long-term scarring and implications for the psychological well-being of the person, that is a huge part of the journey. And if you go to a doctor who doesn't know correct suturing techniques or assist you in the care and management of your wound, that can also cause complications. So thank you, Doctor, for the efforts that you take in ensuring that patients have perhaps a more streamlined journey. And probably on a lighter note, that the story of the nail was rather interesting, and it's the first time I've ever seen a photo of someone who's actually been diagnosed with that. So an amazing diagnosis on your part. Before we move on from that aspect of looking at melanoma prevention and early detection, I would highlight to you some of the resources we have at the back of the room. And one in particular, moving on from what Dr. Roos spoke about, is the Scan Your Skin brochure. And Melanoma Patients Australia, through our Danger Sun Overhead program, were quite instrumental in the development of this resource, along with the Skin Cancer College of Australasia and Queensland Institute of Medical Research. And given that all of us here are familiar with melanoma, but we want to make sure our loved ones know about it, this resource is a really great little brochure to take home and give to people, as Dr. Roos suggested. Let people know. It tells you how you can identify your personal risk of developing melanoma. And there's a little questionnaire in there that QIMR, which is the Queensland Institute of Medical Research, has developed, along with patient feedback, so that it's a really simple tool that they can then be empowered and perhaps prompted to go and get their skin checked. Those are for free up the back, along with the patient guide and other resources. The next phase then for patients is looking at advanced melanoma. So melanoma that perhaps has gone beyond the skin layers and spread further throughout the body. Unfortunately, that is the reality in melanoma, is that we don't always detect it soon enough. And so we're very fortunate today to have Bronwyn Smith come from Brisbane to speak to us about clinical trials. And this is a really emerging and dynamic area. There's been a great deal of investment and research that is translating into better outcomes for patients. We're still seeing some side effects, but ultimately the hope is that patients will ultimately have greater survival, and hopefully, as Dr. Ruth said, die with melanoma, not from it. So if I can just outline a little bit of Bronwyn's background, because again, she is another intriguing and interesting person. Bronwyn joined the Gallipoli Medical Research Foundation at the Greenslopes Private Hospital in September 2012, and since that time she's been very instrumental in phase 2 to 4 clinical trials, and she's looked at things including the hepatitis C program as well as melanoma. Bronwyn has been very instrumental in that area of work and has been a coordinator for a number of metastatic melanoma trials that have been conducted with Dr. Victoria Atkinson. Many of you may know her, and they provide research of a high standard approach. To provide a high standard approach to melanoma research. So Bronwyn will speak with us today about clinical trials, how to access and what they are. If I can get you to welcome Bronwyn. Thank you.
Good morning. First of all, thank you very much for having me here today, Tilly. Today I'd like to speak to you about the role of clinical trials in melanoma research. I'll talk a little bit briefly about some of the recent progress that's being made through trials, but I'd particularly like to talk to you about some of the practicalities of what it means to be involved as a patient in a clinical trial. So, as it's been mentioned, over the last few years, we've seen enormous growth in melanoma research. For us, it's a really exciting time to be involved in melanoma research and to see the results of trials rapidly translating into greater and improved treatment options and improved patient care. Right here in Queensland, we know that we are faced with the challenge of the highest incidence of melanoma in the world. Globally, there are over 65,000 deaths from melanoma every year, and that's been estimated by the World Health Organization. I think it's been mentioned that we know that, sadly, melanoma is not a cancer that discriminates with age. In Australia, melanoma accounts for over 25% of all cancers in Australians aged 15 to 29 years, so young people. Over the last few years, we've seen enormous growth in the treatment options available for patients with metastatic melanoma. So that's melanoma that's spread to other areas of your body. Prior to 2010, patients were limited to pretty much just standard chemotherapy, which showed low response rates and no overall survival benefit. Patients could also access a clinical trial or simply be referred for best supportive care. Today, however, there are now multiple agents which have been demonstrated to improve survival in phase 3 randomised clinical trials. Our cancer guidelines still recommend that patients with stage 4 disease be recommended for trial. So this is allowing patients access to drugs which have not yet been approved for use in Australia, but have been demonstrated to improve overall survival in a clinical trial setting. Now, one of the greatest advances that has come through clinical trials in recent years has been the development of what's known as targeted therapies. Now, through gene sequencing technology, we're now able to identify specific changes or mutations in DNA, which play a role in driving tumour growth. So gene sequencing in this way has drastically changed the way that we think about melanoma and indeed a number of cancers. We know that we can no longer think of all melanoma as the same. But by identifying which particular mutation a patient's melanoma might have, we can consider treatment in a much more individualised approach. By looking at these mutations, we can then design drugs which will target those specifically. And we're much more easily able to determine which drug is going to be most effective for a particular patient. And that's a really exciting development. I'll just talk briefly here, I won't bombard you with science, but I'll talk briefly about one of these mutations, which is found in a gene called BRAF. Now, BRAF is a protein which plays a normal role in driving and controlling the rate at which cells in your body grow and divide. Through gene sequencing, we know that as many as 40 to 45% of metastatic melanoma patients have an activating mutation at the BRAF gene. What this does is drive a signal to cause excess cell growth and hence the development of tumour. So by identifying this BRAF mutation, we've now, through clinical trials, been able to develop a class of drugs called selective BRAF inhibitors. And you might have heard of vemurafenib or dabrafenib. Dabrafenib in the last few months, I think Tafinlar is the other name, has just recently become available on the Pharmaceutical Benefits Scheme after showing success in clinical trials to improve overall survival. Now, obviously, we know as we're learning more about melanoma and melanoma research, we know that every patient is different and there's many different subtypes of melanoma. And this is really just highlighting an ongoing need for melanoma research to improve overall survival and patient outcomes. So for the rest of my presentation, I'll speak a little bit more specifically about clinical trials, what they are and what it means to be involved as a patient. Essentially, clinical trials aim to find out if a new treatment or procedure is safer and more effective compared to what we currently have available. Trials are very much a global project. They're conducted all around the world by universities, hospitals, research institutions and drug companies. They're also very multidisciplinary. If you're a patient on trial, you'll not just have your doctor, but you'll have research assistants, data managers, pharmacists, specialists, which are all working behind the scenes to monitor patients on trial. Clinical trials are very strictly regulated and they follow an approved and carefully controlled protocol. So often melanoma trials, they won't just be run in one location, but run at multiple sites around the world. The protocol ensures that the trial is run consistently, that the data is accurate, and that everything's being run as safely as possible. All research institutions are also governed by a Human Research Ethics Committee, and they have the responsibility to ensure the rights and the safety and well-being of all patients on trial. I'll just give you here a bit of an overview of the drug development process, of which clinical trials are a part. You can see that it's a pipeline and it's a very long process. From the very beginning, early stages of drug discovery in the laboratory, to the point where a drug is approved and made available to use, that entire process can take up to 15 years. We know that 5 to 10,000 compounds, for every 5 to 10,000 analysed at the laboratory stage, only one receives final approval. There's a very long process of rigorous analysis and testing before the drug even reaches clinical trial stage. There's 3 different phases of clinical trials. The first phase is usually run in healthy volunteers and a small population looking at how safe a drug is. Phase 2 is a larger population looking at how effective the drug is in treating the disease area. And phase 3 is a much larger population group which compares the safety and effectiveness to what we currently have available. So why are trials important? Particularly in melanoma, trials are the way forward as we discover new ways to treat and prevent cancer. Clinical trials are the only reliable and controlled way that we can find out the effects of new and different treatments. They tell us how effective they are, and they tell us any risks or side effects that might be involved. So just note that a new treatment for melanoma is only going to become approved and the standard and available for use after it's been proved effective and safe in clinical trials and better than other treatments available. So this could be how well tolerated the drug is, or it could be ideally in terms of the survival outcomes and prospects for patients. People choose to access clinical trials for a number of reasons. To gain access to new therapies that might improve survival. Also to gain access to novel therapies, such as immunotherapy or antibody-based treatments, rather than standard chemo, which can be quite a difficult one to tolerate. Trial patients receive the extra support of a trial coordinator, which is my role at Greenslopes Hospital. I work very closely with patients and step with them through their entire treatment process. Patients also receive closer monitoring of their disease. And altruistic reasons as well. Patients know that by participating in a trial, it may or may not be of direct benefit to them, but it certainly is going to drastically influence the way that we treat melanoma in the future. Now, every trial is regulated by a series of very strict inclusion and exclusion criteria. So this tells us who can and cannot participate in a trial. These are set for good reasons. They're set for safety reasons and also due to the specific research question that the trial is trying to answer. I've just listed some of the criteria here. The type of cancer. I spoke before that there's a lot of different types of melanoma, even in the particular mutation which is involved. The stage and extent of cancer. So that might be whether the cancer is localised in one location or whether it's spread to multiple lesions throughout the body. Age group. Most trials that we run are for adults, 18 years and older. Previous treatment for cancer, as well as other health problems and performance status. So they're usually set to make sure that a patient is able to tolerate treatment. The advantages of participating in a clinical trial. My patients often feel like they have a very active role in their own healthcare. And I think that's really important for patients to be able to feel like they have some control. In a randomised trial, there's generally two types of treatment being compared. On the one hand, we have the standard treatment, which is the best treatment we can offer you currently available. And that's often compared to the new trial treatment. You cannot assume that the new treatment is going to be better than the standard. That's what we hope for, but ultimately that's what the trial is trying to find out. Patients on a clinical trial often have very close disease and health monitoring, so more frequent blood tests, patients coming in for scans more regularly, to see the doctor more often. This can be a big advantage because we're keeping a much closer track on not just your melanoma but your overall health. And I've mentioned before knowing that you're helping in the future of cancer treatment patients. The risks of participating in a clinical trial are the new treatment may be less effective than the standard care. Even if the new treatment is effective, it may not work for you. I mentioned before we're often comparing the standard treatment to the new intervention. If a trial is blinded, neither you or your doctor may not know which treatment you're receiving. So that's just something to keep in mind. You may experience unexpected side effects, and you may need to travel to the hospital more often. This can be a factor for patients who have to travel long distance or trying to juggle other aspects of family life, etc. You will need to read a lot of information and sign paperwork. This can be a bit of an overwhelming factor for some patients, particularly when they're trying to deal with a new diagnosis. As well as treatment being a big deal. And you may not hear the results of a trial, or you might see them in the media before being told. It's important to remember that you can withdraw from a clinical trial at any time, and it's not necessary for you to give a reason. There's absolutely no disadvantage for withdrawal. You will simply go on then to receive the standard treatment or the most appropriate treatment for you as determined by your doctor. So it's important to take lots of time to consider and talk with your doctor about whether a clinical trial is the right option for you. My greatest advice would be to ask lots of questions. I've just put up some questions here that you might want to think about. What is the usual treatment for your condition? And what is the purpose of the trial? Is it for safety reasons or is it for effectiveness? Is the trial appropriate for you? Would this involve you travelling to Brisbane pretty regularly, or are there other factors involved? Are there any other choices available, and what makes you eligible? I've talked about some of the benefits and risks, and also what are the usual costs associated with involvement. Standardly speaking, there's no additional cost for patients participating in a clinical trial above and beyond what would normally be required for standard treatment. On some trials, there is the option of getting parking reimbursed and that sort of thing at hospitals, but that's something you'd want to clarify right from the very beginning. And will I get to see the results? Generally, the answer to this question is specifically no. It can take a long time for the results to be analysed and made available to the scientific community first. But you may hear about the results of your trial from your doctor or in the media. Just finally, I'll speak a bit about finding a clinical trial. With this, I would really say always ask your treating oncologist or your physician first. They're the people who are going to be most familiar with your situation, with your disease, and knowing which trials are available, which you might be eligible for. Having said that, there are some internet searches which can be useful, and I'll just talk you through a couple of these websites. Perhaps the best way is to just Google some of these, but if you want any of this information, I know this is being recorded, or I can pass those on to you. The Australian Clinical Trials website is a useful one. It's broad not just for melanoma or for cancer, but for all disease areas. It has some pretty useful information about what clinical trials are, how to be involved, and what they can involve as a patient. Australian Cancer Trials is obviously more specific to cancer. On that website you can search for melanoma-specific trials, and you can find some more detailed information of what studies are currently recruiting. Every clinical trial run in Australia and New Zealand is required to be listed on this registry, and all of that information is publicly available. This site will go into a bit more detail about some of the inclusion and exclusion criteria involved with each trial. You may also like to look particularly at websites for particular hospitals or research institutions. This is the Gallipoli Medical Research Foundation, which is the organisation I work for. We are based at Greenslopes Private Hospital in conjunction with the Cyril Gilbert Cancer Centre. And on our website, we have details of all of our currently recruiting oncology studies. These are run with Dr. Victoria Atkinson, who some of you might know. And yeah, I'm more than happy to give you any more information about those. Melanoma trials in Brisbane, I've just listed our details there, but also the Princess Alexandra Hospital Melanoma Unit. Victoria works there as well. And they do run a number of clinical trials at the PA. Just in conclusion, we know that the world of melanoma research looks drastically different today to what it did 3 years ago. And we hope that it will look drastically different in 3 years' time again. It's our hope that by working closer and further with patient support groups like MPA and the Cancer Council, and working together for melanoma research, we can offer even greater hope for melanoma patients in the future. Thank you.
So we definitely need to say thank you for an eloquent and very clear overview of clinical trials. I think that this is an area that for melanoma patients is becoming extremely relevant, and unfortunately in some respects is that only option. To further extend upon the question that was initially asked in relation to a new treatment that is being developed, it is still in an experimental phase, and there are a number of manufacturers working on anti-PD-1 treatments. I can inform you that we were advised as an organisation during the week that the one manufacturer has opened their trial in Australia, and that is an early access program. And that will be available through your treating doctor. You need to speak specifically to your oncologist or your treating doctor about that, and your doctor will be able to talk to you as to whether or not you satisfy the eligibility criteria for that early access program. So this isn't now the criteria of a clinical trial, it's actually now their program that they've opened, and that's something you do need to talk to them about. The media recently covered that, and you would have seen that on the news and in the papers. There was a very famous case of a gentleman in Melbourne, Mr. Ron Walker, who had a very good response through receiving the treatment over in the US. So I'm assuming that that's what you're referring to, and I would encourage you all to then be speaking to your doctor. The criteria for that are very strict. You need to have received every available treatment option before you can even be considered, and then there are also some other parameters. So I hope I'm not overstepping the line in sharing that. The one manufacturer has opened that already, and that's what the media was covering, and another manufacturer has advised that their treatment, which acts on that same anti-PD-1 level, will be opening in Australia shortly. Just a week ago was opened in the US and is now going to be available to Australian patients in the very near future, we're hoping, although there's no time frame provided, but I have my fingers crossed, as do all of our members. Please be aware that with melanoma, it's such an emotive and trying area. The feedback we get from our members is that we look well, and yet we're walking with a very significant, severe, distressing condition. And it's really important that when we come together like this, that we acknowledge the strength that we provide each other and the hope that the doctors who act in the early detection and diagnosis setting and the clinical researchers and the treating doctors and specialists provide us. And I think that if we could take this opportunity to just give them a round of applause publicly, and again thank our speakers for presenting with us today. So the only other aspect that we'd just like to share with you, I know it's a long morning, but hopefully a very worthwhile morning, is that there are some opportunities available for you specifically here in Toowoomba, and also just more broadly for those of you that have travelled, and I'd really like to share those with you so that way then you're receiving every possible support for you and your family and your loved ones. And also I know some of you have come along today to find out information for loved ones who are interstate or overseas potentially, and it's really important that you know that the programs we talk about can be found in those regions, and Melanoma Patients Australia and the Cancer Council are keen to assist you. So I'd like to invite Amber Copeland up today. Amber is based at the Toowoomba Cancer Council office, and she can share with you some really important information for your community. Thanks, Amber.
Thanks, Tilly. Well, simply my role at Cancer Council Queensland is the Cancer Support Coordinator, and as Tilly mentioned, a great level of distress exists around a diagnosis of melanoma, and we're keen to help in any way we can. Not only for the patient, but also we know that distress is felt just as much, if not more, for the people who are walking the journey with the patient. So looking over to our banner, the ways that we can help us by ringing our wonderful helpline. The helpline becomes a portal of access to all of our programs. All of the programs that you see there are free and are provided with the generous donations from all the biggest morning teas and events that we run. So our free cancer counselling service, we've got Dr. Carly Fay, who comes up to our Oliver McMahon Lodge, which is just over the rise there. She comes for face-to-face appointments on a fortnightly basis, but can talk to people over the phone at any time. We have our practical support programs, which are our lodges, our wig and turban service, and some financial support as well. And then our wonderful peer support programs, which involve chatting to another person, a trained volunteer who's also had a melanoma and can buddy you along your journey. Somebody that you might ask questions about their treatment that might parallel your treatment and help just take away a level of fear that might exist there. And I'd just like to acknowledge Kim in the room too, who with MPA runs the local melanoma support group. So check in with Kim, she does a wonderful job, and another great avenue of peer support there. And of course prevention and early detection are there too. And just locally, some exciting news is that we're actually closing down our Harries Street office, and all of our support programs are going to be at our Oliver McMahon Lodge. So the counselling, my role, the residents there will all be housed together. We're opening up a wellness centre in one of the rooms, and what that means is that we can provide free massage and free physio to people with a cancer diagnosis, and that's simply by calling the lodge and booking in to benefit from those services. We've got a great team of local professionals who've been able to provide that pro bono. And so then we're going to open a community hub at the High Street Plaza, and that community hub will house all of our SunSmart gear, the hats, the sunglasses, the cosmetic range, and as well as provide a community meeting space, and our fundraisers will all be housed there as well. So parking won't be an issue, which is fantastic, but we're really looking forward to that opening mid-July. Okay, thank you very much. Over to you, Tilly.
Thank you, Amber. So just some of those opportunities that Amber outlined, she's wonderfully brought along a huge cachet of resources for us to review. They're available for you to take at the back, including the details of the new lodge that is opening. It's a wonderful opportunity for residents in this community. I think that Amber did touch on something that we now need to speak about from the Melanoma Patients Australia perspective, which is the wonderful community-based peer-to-peer support group that is run by Kim Stewart. And Kim, if I can just get you to put up your hand and come forward if you're willing and able. So Kim has been working in this area and being a wonderful advocate for melanoma patients in this region for a number of years. While Kim's standing up, I want everyone to give her a big high five, clap in the air. We are indebted, absolutely indebted. And it is without Kim's lobbying and pushing and really hankering for a day like today that this has happened. And it's all because of Kim and the wonderful members who are here today. And those members that are here, if you want to put up your hand and say g'day too, that's wonderful. The group up here in Toowoomba is really wonderful, and they're keen for you to come along and meet them. And it is a group that comprises of not only melanoma patients of varying different stages, but also of carers and supporters. So I promised Kim I wouldn't hand her the microphone, but rather she would love to meet you afterwards over morning tea, and the members will be happy to speak to you and tell you about the group and welcome you along. So thank you, Kim, but that's who you're looking out for. Moving forward, there's just some things to touch upon that we've spoken about and the various speakers have touched on. There are opportunities through our organisation for you to engage with education in workplaces and in schools, and our Danger Son Overhead program has been recognised through various industry organisations and government as being a really great program, and I know that the Cancer Council also offers a similar program, and we would encourage you to look at the back of the room for information if you have a business business, or if you have a loved one who works in an outdoor industry, or even who works in an office, because we know that you're at risk even if you work indoors. We also offer telephone support similar to the Cancer Council, but that then links you in with our group, and particularly with Kim. And again, we have a 1300 number, 1300 884450. And I would strongly encourage you, if from today there's anything that you've heard and you would like us to clarify or find out more information, then let us know. Melanoma Patients Australia is developed by patients, by 2 young patients who are in their 20s dealing with melanoma back in 2006, and both struggling with advanced disease and trying to work out what they could do. And from that, Melanoma Patients Australia was formed. And we have now grown in strength and numbers to be one of the peak organisations within Australia to offer advocacy, awareness, information and support services, programs and initiatives for melanoma patients across Australia. And the way we operate is that every program that we offer for patients is free of charge. These forums are free of charge, and we make sure that you have direct access to information as best we can. But in order to be a representative organisation, we rely on you, and so it's really great if you ask the questions and you let us know how you are going on your journey and what we can do to assist. And a good example of that is just recently we participated in a House of Representatives inquiry into skin cancer, and we presented the melanoma patient's perspective, because melanoma is very different to other skin cancers, and it's vital that our members have a voice. We also have members go out to various conferences. For example, the Skin Cancer College of Australasia's conference that they host every year, and Julie Fraser, who's down the back, one of our board members and also the facilitator of our Brisbane group, has presented at that along with other members, and really tries to share the patient experience with the clinicians, because their bedside manner is vitally important. The information I've touched upon includes the patient guide, which again you've seen on a number of occasions, along with our brochure, the Scan Your Skin brochure that I touched on before. And you're probably wondering why there are some crazy cartoon characters, and that's because we provided patient input into the development of the MediKids Explain Advanced Melanoma booklet, and we've brought those along today. MPA has the exclusive distribution in Australia, and they're a resource that explains melanoma in a very easy form. It uses cartoons so children can access it, and also for people who just want to understand what it is that all that gobbledygook the doctor might be talking about. This gives you a different way of understanding it, and it does have a specific focus on immunotherapy towards the end. Lastly, Melanoma Patients Australia strongly believes that there is hope. And hope is a wonderful part of any journey. And so this year, our theme for our annual gala dinner, to be held in Brisbane in August, is hope. And part of that celebration and acknowledgement of our patients, of our members, and of the researchers and the clinicians will involve a program that will highlight hope and what hope means to you. And because we're up here today and we have these wonderful cameras, we will be inviting you to share with the camera, if you feel you would like to, what hope means to you. Because in that room there are going to be people who matter and who can make a difference, whether they're fellow patients, whether they're loved ones, carers and supporters and friends, whether they're industry leaders, doctors, clinicians, and definitely members of Parliament. And we want them to understand what hope means to us, and why it's important to invest in research, and why it's important to believe in support programs and peer-to-peer initiatives like what MPA and CCQ offer. We also want them to know what hope means for you, because there are so many wonderful patient stories that emphasise that there is hope in melanoma, that it's not all doom and gloom, and that for those that perhaps have a more advanced disease, opportunities are arising, and we want access to those. So I would encourage you and invite you to just make a small statement if you so choose, and we will set the camera up, and it will just be looking at the camera and saying what hope means. Or it could be as simple as just putting your voice to the statement, I have hope. Because if we can get that message through, we can united make a difference. And so I hope that today you've come away with some hope. The clinical trials are developing as we speak. Here in humble Toowoomba, on the other side of the world, the ASCO conference is on, and I know that that's a big meeting where all the doctors from around the world and the researchers come together and they speak on latest advances. And anti-PD-1 was going to be discussed there, and we were hoping that there will be some wonderful news shared at that meeting, and we will be updating our members accordingly. So there is hope. Thank you for coming today. Thank you for being a part of this wonderful initiative. And please stay as we share in morning tea towards the end of the room. We probably have finished a little bit early, so I'll make sure that that comes out. But if anyone does have any questions, our speakers and our facilitators are going to be here. But more importantly, I would really encourage you to look to the people around you and support each other and offer the hand of friendship and keep in touch with one another, whether it's through MPA, Cancer Council, or indeed just personally. So thank you very much.